Hello and everyone, and welcome to today's webinar. I am Trevor Smith-Miller, and I'm the Communications Manager with the Canadian Cancer Survivor Network. Thank you everyone for attending today's webinar. And if you're new to our webinar series, CCSN is an organization working with cancer patients and survivors to learn about the complexity of our health system, connect with others to plan action, and act on those plans to create better outcomes and healthy survivorships. Please visit our website. You'll find plenty of information like news, events, and information on various types of cancer and other resources. Now, this webinar is being recorded and will be available on our YouTube channel, and a link will be provided to the email that you registered with for this webinar. Now, we will have a quick Q&A session at the end, but if you would like, anytime during the presentation, please put your questions in the chat function, and we will get to them as soon as we can. And at the end of the talk. And now on to our presenter. Dr. Ambreen Sayani, MD, PhD, is a scientist at the Women's College Research Institute, Women's College Hospital in Toronto, Canada. She is a health equity expert advisor for the Canadian Partnership Against Cancer, a member of the Medical Advisory Committee for the Canadian Cancer Survivor Network, and co-founder of Equity Mobilizing Partnerships in Community. Dr. Sayani holds a 6-year Career Development Award from the Canadian Institute of Health Research to lead patient-oriented research in Canada. Her research program focuses on improving cancer care outcomes for all population groups, in particular the underserved. Her areas of expertise are patient engagement, health equity, and cancer care. And this is not the first webinar that Dr. Sayani have done with us. She has done a couple of CCSN webinars in the past. So without further ado, I would like to introduce Dr. Ambreen Sayani with her talk, Social Inequalities and Cancer.
Thank you so much, Trevor, for the generous introduction, and it's great to be back here with CCSN. I have been given a pretty theoretically dense topic to talk to everyone about today, social inequalities and cancer. And when looking through things that I'd cover with you today, these were a couple of the objectives that we came up with: theories and definitions of social class, the link between social class and health inequities, and then how to use Bartley's models of health inequities to understand how these things function together. But my objective is not to turn everybody into an expert sociologist at the end of an hour. Instead, I'd be super happy if you walk away in your toolbox, going away with a couple of key terms, some new concepts and models, and then a reflection on my call to action. So let's start with some terminologies that we're all talking about and thinking about the same thing. What do we mean by social class? Social class, it's a term. It's a term used to describe a group of people who occupy a similar rank order. And this rank order is determined based on economic wealth, social networks, and cultural capital. Very often, this rank is determined by the distribution of power, privilege, and prestige across a society. How does it lead to social inequity? Well, when we distribute power, privilege, and prestige unequally across a society, people who have more power, more privilege, and more prestige are able to gain more and more assets and resources, and therefore creating further differentiation between the groups.
Can you hand me them? I'm trying to take notes.
When the differentiation between the groups has been reinforced through policies and procedures that our institutions and our systems continue to operate and function on, this is called structured inequity, because it's very difficult to break out of those class ranks. So how do we even measure this when we talk about it as a concept? We can measure it using occupation, and this is what's done very frequently in the UK, looking at the differences between skilled labor and manual labor, also working in degrees of decision-making within an occupational role. Another way to look at social class is by looking at metrics of education. You can look at it as a continuous measure in terms of the number of years of education received, or categorical Did a person pass out high school? Did they go to university? Yes or not? But by far the most frequent measure of social class, which has been correlated so strongly with health outcomes, is income. And income is determined it's determined by relative estimations of a person's income, either through surveys, although sometimes those are incomplete, but also at a regional or geographical level through postal code data and estimations. For the rest of my talk, I'll be focusing on income as a categorical measure of social class. Let's take a quick look at the relationship between social class and health. And these are 4 quick slides to show you some of the data. And I agree that the data that I'm showing you is dated, but my team is working on more current statistical metrics. If we look at life expectancy at birth, well, that's gone up for all of the income quintiles, but by far there is a difference between the lowest income quintile group and the highest. If we look at infant mortality rate, we can see that that's reduced over time, but there is this steep difference between the groups. Ischemic heart disease, exactly the same. Lung cancer mortality, gone up over time, but a continuous difference between different income groups. So the question is, okay, we have these differences, but how significant are they and why should we care? Let's take a look at some of this data. If Canadians were divided into equal groups based on their income, in this study, they looked at the difference between the wealthiest 20% and the remainder 80% of the Canadian population over a 16-year period. If all the Canadians were as healthy as the top, there'd be 40,000 fewer deaths each year, every year. That is equivalent to 110 deaths each and every day. And I'm going to quote my mentor and PhD supervisor, Dr. Dennis Raphael, when I put a Boeing 737 up there and say, if a Boeing 737 were to fall out of the sky every day, the newspapers wouldn't stop. We'd all be baffled and we'd be screaming for action. But when 110 people die every day because of social class differences, it doesn't make the same kind of noise. So how can we use social models to help us understand health inequities? Because once we understand them, we can begin to unpack where can we take action and how can we change some of the things so that everybody has better health outcomes. And I'll draw on Mel Bartley, who's a British social epidemiologist, and her models of health inequities. And she's categorized them into the behavioral, psychosocial, material, and life course. The behavioral model of health inequities basically posits that differences in health outcomes are due to differences in lifestyle behaviors and choices that are related to the social class position a person occupies. So basically, in our society, when we have social structure and social stratification shaped by policies and economic decisions, creating social class differences, what happens within the social classes is that there is a clustering of different risky lifestyle behaviors, such as smoking, alcohol consumption, lack of exercise, and all those things which we perceive as to be healthy, you need to have this certain lifestyle. The psychosocial model of health inequities, it posits that differences in health outcomes are based on differences in the relative perceptions of well-being between different class groups. So when you have an unequal distribution of power, privilege, and prestige, and you have a very strong hierarchical understanding of where you lie on this ladder, there's chronic activation of the stress response. And that leads to a higher predisposition to disease. Again, based on social class positioning, people will have a higher predisposition to disease. The material model of health inequities posits that differences in health outcomes are basically due to differences in the ability to choose between resources that are available to you. If economic policies shape the distribution and redistribution of wealth, then it determines the degree of access individuals have to the social determinants of health. It also structures how people can access healthcare or access resources to better their health. This in turn means that people with a lower social class are unable to access these opportunities and live a healthier life. The life course model of health inequity will tell you that there's an embodiment of risk over the life course. So the more risk events you have over your life, the more likely you are to have poorer health outcomes. And this accumulation and embodiment of risk over the life course is different for different social classes. So how can we use these social models to understand inequities in cancer care? I would think a lot of people on this call today are familiar with the cancer care continuum: prevention, early detection, diagnosis, and treatment, and then following on through to survivorship or end-of-life care. Social class and social location are so strongly tied to each and every part of the cancer care continuum that by the time a person has reached the end of the continuum, you will notice stark differences in health outcomes. And we've documented this for breast cancer, access to hereditary breast cancer therapeutics, lung cancer, and a variety of different tools and models and resources that we've thought about to think, how do we unpack the inequities and how do we understand where do we take action? I'll do a bit of a deep dive into the lung cancer care continuum to bring to life some of these examples. This is the social gradient in lung cancer survival, and we can see the differences in the groups, which is stark and clear. But what we can also see is that the social gradient between the groups is widening. When it widens, it means that those occupying a lower social class or having lower income are less likely to survive, and that this inequity is widening over time. So let's use Bartley's models to understand how does this relate to lung cancer in any case. When you have a clustering of risky lifestyle behaviors, and by this I mean inability to access fresh fruits, fresh vegetables, lack of exercise, smoking, inability to quit smoking, these are so heavily based on where people live, the social class position that they occupy. And one of the key parts of this is that if you try to tell people within a certain social class to stop smoking, when smoking is a way to cope with the stressors of daily living, or is a part of the embedded environment that they live in, for example, in a homeless shelter, it is highly ineffective unless you change the class environment, that an individual will be able to respond to situations telling them to improve your lifestyle behavior. You need to stop smoking, you need to eat better, you need to exercise. And the question that people will tell you is how and why, and that's just not possible in my circumstance. If we look at the psychosocial model of cancer inequities and think about how it relates to cancer and lung cancer in particular, the chronic feelings of subordination, oppression lead to an activation of the stress response. And what happens is that there is a downregulation of the immune system, and therefore tumors found in people living with a lower income are known to be more aggressive, and they are known to have a lower immune response within the blood circulation. Some of the ways that this has been treated or dealt with in the lung cancer care environment is offering people stress pills and offering psychosocial therapy to people who have been diagnosed with lung cancer. And the question is, how do we deal with stress responses that are a result of societal forces? And is psychosocial therapy the treatment that would be relevant or effective for this kind of class-related difference? The material model of cancer inequity is about the social determinants of health. And it's about choosing within the limitations of one's choices. And I really like that phrase because all of us in different realms of our lives have a different set of options that we can choose from. And those options are based on the availability of resources that we have. It's based on the networks that we have within society and how we're able to use those to our advantage. When we look at lung cancer in particular, how is one able to access lung cancer screening, for example? What does it look like in terms of transportation, access to care, ability to take time off work, ability to pay for parking? How about access to treatment? In Ontario, people pay an average of $500 a month out of pocket to access cancer treatment. That's a lot of money. So again, the question is, what material resources are available to people, and how are they able to use those in order to better their health and gain better outcomes? And finally, the life course model of cancer inequities allows us to unpack and understand how and why, for example, people in occupations such as being a male waiter or a manual laborer have higher rates of smoking consumption, higher rates of environmental carcinogenic exposure, but also a greater risk of lung cancer. And how has this risk left permanent biological imprints on their body over the course of their lifetime? But for me, the key part is always about action. Because I'm a critical social scientist, my focus is less on the descriptive, but more on the what can we do now that we know this? And for me, it's about understanding the loci of action that these social models unveil. And I like to think about improving health outcomes as thinking about a river stream. And strategies to improve health can fall into one of these three categories: upstream, midstream, or downstream. Upstream action really means acting at a community and societal level. It means redistributing resources at the jurisdictional level and having everybody the opportunity to access care and further their health in the best possible way. An example is giving all citizens a living wage. To act midstream means to act at the individual level. And this is focused on improving health opportunities for each and every individual. For example, ways to promote a healthy lifestyle. Are we giving smoking cessation kits to individuals? Are we giving them a healthy eating toolkit guide? Are we providing coupons for people? And anything that would facilitate the individual to be able to act and take action to further their own health. To act downstream means to target disease at the cellular level. And this is, when we look at drugs that target biological pathways or precision medicine, if you may. The key idea is that the further and further downstream we go, the benefits become personalized. And the benefits are limited to those who can either access that treatment, adopt their lifestyle behaviors, or benefit from the resources that are provided to them. The onus falls on the individual the more and more downstream you go. Strategies that are upstream tend to benefit everyone and have a whole of society approach, and therefore the benefits are much larger scale across the entire population. So what could the intervention levels look like for cancer inequities? And we can look at the downstream, midstream, and upstream. The locus of action for downstream interventions in cancer inequities involves processes that are biological and physiological pathways. These precision medications targeted towards social class groups can impact health inequities. Taking midstream action, making sure, for example, lung cancer screening is more targeted towards groups that are underserved, making sure that the prevention packages that we create or the opportunities to access care are more thoughtful, are more inclusive, are tailored and co-designed with people can also improve health inequities. But by far, trying to tackle social problems at an individual level will always fall short. We must never forget to act upstream in tandem with downstream and midstream processes. We must tackle the social determinants of health at the root cause and make sure that access to quality social determinants of health is something which every person can avail and have an opportunity to access better healthcare and further their chances of surviving cancer. I want to introduce to you here two sociological terms. This is the first one. It's called a lifestyle drift. And increasingly, we see this great recognition of health inequities, particularly around the time of the pandemic. And we have this acute understanding that the social determinants of health shape health outcomes. But then if we continue to focus on individuals and how they can better their health, how they can adopt a healthier lifestyle, how they can access treatment, how they can receive timely care because of when they reach out to services, and we neglect the social forces that are driving all of these to begin with, it's called a lifestyle drift. So we acknowledge the social problems that cause these health issues, but then we continue to push the onus of action onto individuals. And this lifestyle drift will not help solve the sociological problem. And this is the idea of fundamental cause theory, which was released by Lincoln Phelan in 1995. If we're constantly trying to put a Band-Aid on people's individual problems or solving individual level conditions, without even thinking of the fundamental causes that are driving these issues in the first place, we will not inherently reduce any inequities in any significant manner. So what does this mean in terms of income and wealth in society and thinking upstream? Because of the redistribution and distribution of resources, it's important to think of income inequality. And income inequality is the extent to which income is distributed unevenly in a country. This is a pie, the Canadian income pie. And if we look at the distribution of wealth across all of the quintile groups, what's pretty outstanding here is that the top two income quintile groups hold around 3/4 of the entire Canadian wealth. The Gini Index, which I won't go into much detail on, is a measure of the degree of inequality, income inequality in a society, where 0 represents exact equality and 1 represents total inequality. And as we can see in this graph, over time, we see that income inequality in Canada has continued to rise. We are just simply not redistributing income as effectively as we did before. Let's take a look at some numbers. The lowest quintile group in the 1980s, and if you look at the number for 2011, their income went up by around $4,000. And if you look at the highest income quintile group, it went up by around $25,000. So therefore, even though all groups continued to gain a certain amount of income, the amount which each group got was significantly very different, with the highest income quintile group gaining much more in terms of wealth and resources than those living with the lowest income. And why did that happen? We were distributing income much more effectively in the 1940s when our taxation policies meant that income was redistributed to a more equal level. In 1995 is when we had, in 1980s and 1995 is when we started to see austerity policies kick in Canada. And therefore, social housing was frozen, We had clawback on the welfare, around 22% of clawback from the social safety net. Poverty, homelessness, child poverty, all of those continue to increase over time. And as we've seen, that once you start to increase income inequality, those at the top already have means and opportunity and resources to further their wealth, creating a further distinction between the groups. So why is this, again, such a big deal when everybody's income level is increasing? It is a big deal because GDP, the gross domestic product, which is a measure of wealth, does not tally with the social health index. The social health index is a measure of how well a society is in terms of infant mortality, child abuse, teen suicide, school dropouts, unemployment, out-of-pocket expenses, and affordable housing. And this is what our reality looks like in Canada. People are using food banks. There's excessive stress. People are couch surfing. We're talking about saving people from hunger. We have an extreme affordable housing crisis. And people are working multiple jobs to keep a roof over their head. But this is how it translates and leads to a widening gradient in lung cancer. And in all the other cancers, when you think of when the social problems aren't addressed, how do we question when and how we will improve inequities in cancer? So in summary, social, political, and economic decisions shape how society is structured. An unequal distribution of resources does create hierarchical differences, and this has implications for health. We know that social class influences cancer risk, prevention, early detection. We also know that there are multiple loci of action, and that it is important to have precision medicine. It is important to have access to cancer screening. It is important to have timely and effective care available to everyone. But all of those things must work in tandem with upstream measures so that we have a more evenly distributed society. Because unless we do so, we won't make any significant impact on the fundamental causes of inequities in cancer care. And I want to leave everyone with this, that income inequality is not inevitable. It is a decision that we make, and it is a decision that we can strive to change. It means we can make better choices moving forward for a more equal society. So my call to action to everyone is to recognize the forces that create this, to understand how it runs through the whole of society, impacting everyone. We need to improve communication. We need to educate people about these differences. We need to lobby governments for change, and we must advocate for a health in all policies approach. So thank you. I look forward to any emails or questions.
Thank you very much, Dr. Sayani. That was a very informative talk. So if you could, anyone who has a question, please put it in the chat and we'll get to that right away. One question that I have, it seems that most people, whenever they are thinking about the healthcare field, they don't often think that that they'll take on the hat of a sociologist, or even just even in some cases, almost seem to be going into almost a political science field of this. So in your experience, how has that kind of evolved over the last couple of years? Because it seems that the more that we kind of talk about, the more we learn, it seems that healthcare has kind of started incorporating these different fields that are not just strictly healthcare sciences related.
Thanks, Trevor. I think there's an increasing understanding within the healthcare sphere that around 75% of your health depends on the social determinants of health. And everything else, access to treatment, access to timely care, those just account for around 25%, including your genetics. For those of us in the sociological space, we've had this understanding all along. But I think it's a very exciting time to see both the fields come together in such a tight manner where we can merge the literatures and begin to unpack and see where do we find insights that are meaningful and actionable, because just working on the downstream determinants of health hasn't been working. And there's a lot of, I would say, 2 waves of health equity data that has been very descriptive, describing the inequities, describing what we see as the differences, working downstream and not finding, the inequities are still there. So how do we think about it differently? And applying a sociological lens gives us more avenues to work together in a multi-pronged way.
Mhm. We have a question from Letta, who, it's a very fantastic question, and thank you for asking that. What do they do in countries that do better than Canada in their healthcare fields?
Yeah, and I think the European countries, for example, Denmark and Sweden, they do a fantastic job of wealth redistribution. So if you look at their GDP, it's quite similar to Canada, but then when you look at the income inequality, it's far less. So they tax very well. They have better regulation policies, and it's this whole idea of we're redistributing the income so that people have a more equal access to the resources they need to live more healthy.
Thank you.
Excellent. Thank you very much. All right. Let's see. Pauline asked, does women's lack of representation in company boardrooms and political leadership affect the distribution of research monies going towards gendered types of cancers being researched?
That is a very interesting question, and I'm not sure if I'm the person to be asking that question, but I think we do know that more diverse representation in any aspect of research, or whether it's grant funding, whether it's the research question, whether it's the study design, the interpretation, even the dissemination of findings, the more diverse your group of people, the more valuable your work will be, because it just translates much better. And I think the same goes for women representation.
Excellent. And thank you very much, Pauline, for that question. Now, we asked about the Western countries and how they do things, but is there any, into your knowledge, is there any other countries that are not typically considered Western that Canada can learn from, to your knowledge? Because again, it's not just European countries and the West that have healthcare and have cancer issues, but from a global perspective, is there any place that we kind of are looking to see what they do for their healthcare to improve outcomes in cancer?
That's a really good question. And the truth is, even in my own comparative work, we tend to cluster the OECD countries together, right? And therefore, we're looking at high income countries and how they resource and distribute. I can certainly look into that question for you. I think it's a good one, Trevor, and get back to you on that one.
Mm-hmm. Another good one from Leda. How does geography factor in with all this? Does geography make it harder to have hospitals nearby, considering how large Canada is as a country geographically?
Yeah, I think when we look at some of the features of, and again, we can use the models of health inequities to begin to understand how rural, remote locations might factor into that. So what are the behaviors related to rural and remote location? What are the resources that are available, material resources in relation to rural and remote locations? I think in Canada, when we're talking about income distribution, it's 2 parts. So you have to have the resources within the healthcare system. And in a vast geography, I think we're probably talking about hospitals and access to physicians and the ability to interact with the healthcare system from the healthcare side. Income redistribution will allow people on their own ends to be able to have the resources that empower them to work. I'm not sure if it would be such a clear-cut difference, because I would think we're looking at slightly 2 different things. One is empowering individuals in their social class, and another is making sure the healthcare sector has enough services and facilities spread out across our vast geography so that people can interact with it at different touch points and avail benefits.
Now from Louise, to what extent is our federal, provincial, territorial division of responsibilities helping or hurting us in dealing with health inequities? If so, are there solutions?
Louise, it's very nice to see you again, Louise, and that is a very complex question that would probably require a workshop of people sitting from the federal, provincial, and territorial regions and thinking about what are the policies that are currently in place. And one of the interesting things that my team and I are looking at are the CERB income distribution during the pandemic and how that influenced income distribution. What is the responsibility of each layer, and how does that impact resourcing and opportunity? And you've added to there, Louise, do you want to comment on that? You are deep in this space yourself, so I'm sure you'll have interesting things to add.
Well, this is your area, Ambreen. I don't want to muscle in on your area, but I really hope that we will. One of the things that's supposed to happen with this new health transfers deal is that the provinces are supposed to be starting to transparently monitor that they are helping in the 4 shared priority areas, which includes modernization of the health system and other health inequity areas like mental health and addictions and so on. So, I mean, my call out is that we should all be, and Trudeau said this, he said the judges of whether this is the right thing to do or not is going to be the media and the public. So I think as the public, we really do need to be looking at whether they are meeting those shared goals and whether that is helping to reduce health inequities, for sure.
I mean, I can add that, in Ontario, which is where I'm based, we've seen the provincial government claw back on, for example, services to seniors, and it leaves you wondering where that's coming from. And I think for those of us, again, in this space, we understand that will just increase inequities because those that have access to resources will be able to pay for those services, will be able to avail them timely. But seniors that don't have access to those resources are the ones that are going to bear the brunt of the unequal health outcomes. So these are provincial decisions, and I would have liked to have seen much more outrage at that. And I wonder if anyone on the call has suggestions or ideas on what would be a good way to rally together and talk about some of these things, which are glaringly going to increase health inequities.
Well, that I can comment on that, if that's okay, Ambreen.
Yeah.
There's a group that's come together, and I'm one of the 7 members of the steering committee, and we're calling ourselves Patients for Accountable Healthcare. And we're going to be developing working groups in each of the provinces of people who are interested in being judges of how things are going in their provinces, and also, sharing with everybody else both the best practices that happen and the worst practices that happen. And I think, so we're very happy to have others join us. That you can never have too many cooks on this one. So if people are interested, they can always get in touch with you, and you can let me know, if they're interested. But I think that's what we're going to need to do, is become a kind of citizen/patient group coalition that are the judges of what's going on quite publicly.
Right, with help from media. So
exactly, and then take that to the media. Exactly.
Thank you very much, Louise, for your comments. I really do appreciate that. Now, sorry, Oh, here we go. So Claire LeBlanc's earlier question from Pauline, where do gender inequalities stand in the last 5 years? Sorry, I don't know where that question went to. Oh, here, yes. I guess for when it comes to gender inequalities in poverty, if Claire, you'd like to kind of talk a bit about your question for that. Yes, if you can talk to about where gender inequalities I guess if then gender inequalities, how that they kind of relate to poverty in this sense.
So I think a key part of this is women's structured roles in society and the unpaid work of what's been described sociologically as the unpaid work of social reproduction, which is the idea that women are the unpaid resource that raises the next generation and is responsible for their caretaking, for their education, for their general well-being. But because that's all unpaid labor, their own access to resources, material resources, social networks, cultural capital is significantly impacted. And I think if we just look at I haven't showed any gender-based analyses here today, but just from this basic understanding of women's structured role in society, I think it would be very easy to, again, apply the same Bartley's models to understand how at each and every point, being a woman, being in a structured role as a woman in society, what does that mean and how does that impact prevention, cancer, cancer risk, and access to early detection and treatment? If that's a topic of interest, it's certainly something that can be an entirely different webinar because there would be different statistics and models that would be built into that.
If that is a webinar that you're interested in doing, or if you know anyone who's interested in doing that, that is a fantastic topic that we definitely would like to explore here at CCSN. Ian, given the high out-of-pocket health expenditure associated with a cancer diagnosis, I think that makes patients vulnerable to catastrophic expenditures in the unequal distribution of wealth in our society more than income. Could you comment on that?
We actually did a paper on this, and we spoke to patients in Nova Scotia, and we were understanding what was the impact of the cancer diagnosis on their financial well-being. There's a significant out-of-pocket cost and significant expense relation, and I can put, maybe I can share the resource with you later for that paper, but the idea that unless we distribute and redistribute wealth more equally, we're setting people up for financial toxicity. And that severely limits the choices that people who are surviving cancer or living with cancer, trying to get back to work with cancer have. We had participants in that study talk to us about if they don't get back to work, they will lose their house, that they're so unwell, but they don't have a choice. So people's choices are so constrained because of this unequal distribution, and it has significant impacts on their overall well-being, quality of life, and outcomes and survivorship from cancer.
Excellent. Thank you very much. I think that is all the questions we have. If we may have a little time for one more question, but right now I'm not seeing any. Yeah, that looks like that. I think that is. Alrighty, and thank you for sharing those resources, and thank you very much for everyone for your questions. It was a fantastic conversation that we continue to have here. So I would like to thank Dr. Ambreen Sayani for an amazing talk and for fielding some very good questions and taking care of that. Now, this webinar is one in a series that we have going on this year at CCSN. In fact, I believe I saw one of the presenters for the next webinar in attendance. And if you want to know the information about that, we are sending out the emails. And if you have subscribed to our emails, Just one quick note, we are noticing that Google and our email distribution software, they're not getting along as well as we'd like. So if you think that you're missing out or you feel that you are not getting these updates, just head on over to our website. There's a option to resubscribe to our email and send out the word loud and clear that we have this webinar series, as well as one that kind of relates to this, our Cancer Survivor to Financial Survivor series, which is also extremely interesting. And we have a lot of resources on that that are planned in the future. All of our webinars for all of us can be seen at survivornet.ca/webinar, where you can find all of them on demand. So once again, I'd like to thank Dr. Sayani and hope that everyone has a fantastic day.